Good afternoon, everyone. I will talk about Clostridium difficile infection in ulcerative colitis patients. Here you can see my disclosure. And I'll start talking about just a little bit on ulcerative colitis. I tried to read your program, but it was in Greek, so I didn't understand nothing. So I don't know if you have an IBD section, actually. However, I just will say a few words about the epidemiology of this disease and why the infections are so important for us. A few words about the epidemiology of Clostridium difficile infection in our patients, some data on clinical outcomes of infection, diagnosis and therapy, especially a few more words about new treatment like fidaxomicin and fecal microbiota transplantation. So starting from ulcerative colitis, what is important to know is that for sure you know this is a chronic inflammatory bowel disease that could involve different parts of colon, involve just the mucosal layer in our patients, so it's a little bit different than Crohn's disease, and could interest in mostly it's a pancolitis, but you could find a disease localized just in the left colon or a proctitis. The annual incidence and prevalence of IBD is quite high, and what is really important to know, I think, is that when the first case won in 18th century, and what happened is that now with the globalization, we have more and more cases in the East countries in the world. The etiology is a multifactorial etiology, so for sure there are some genetic factors, but together with environmental factor and probably the involvement of microbiota and enterobacteria and the antigen presentation on the mucosa, irregular immune response is activated, and finally we have the disease. And because of this complexity of factors, we have the biggest problem. We have not just one drug to treat our patients, but we have, I think, every year more and more mechanism of action understudied to find something that could treat most of our patients. The clinical course of the disease mostly is a disease with a flare, the first flare, and then a reduction in severity of symptoms over time. But we have some cases in which you have symptoms that increase over time, or chronic and continuous symptoms. In this case, you have patients that are medically refractory and that need surgery finally, or you could have a chronic and intermittent symptoms situation. Half of our patients have ongoing disease activity, and after 1 year after the diagnosis, we have a rate of colectomy that is 1 to 5%, and it increases after 5 years. The rate is 3 to 8%. So moving to the symptoms of disease, generally we have malaise, abdominal pain, we could have fever. Generally we have the most important symptoms probably is the bloody diarrhea. But what is important to in this presentation, I think, to know is that our symptoms could have an overlap when you have an infection. So this is the biggest problem for us. And for this, when we have a new flare, I mean, we have new symptoms in our patients, the first thing that we do every time is ask for fecal examination, coproculture and parasitological examination, and Clostridium difficile infection too. This is every time, because every time the first thing to do is to exclude that we have a new infection in our patients. What about epidemiology? We know that the risk of common infection in people with inflammatory bowel disease is higher than control. You can see here that any common infection, and especially in ulcerative colitis, is higher, and specifically gastrointestinal infection, if you compare with control, is higher, 1.46. And if you just try to understand if the medication use could be related to the risk of infection, it seems, but it's not the same in all of the studies, but it seems that steroids, for sure, but immunotherapies and biologics therapy are associated with a higher risk of infection in general, I mean infection. Which are the risk factor to have a Clostridium disease infection in UC patients? So probably the disease process itself. Patients with UC have a defective innate immune mechanism, could have malnutrition, could have comorbidities. However, comorbidities, it's common to IBD or non-IBD patients, could have an ineffective immunization, and this is related, for example, to drug therapy that they use. And another important point is the dysbiosis that we find in our patients. In this very interesting review published this year, the author showed us the risk factor to develop in IBD patients to develop Clostridium difficile infection. Most of the study are review, and you can see that more or less the identified risk factors are the same. So the age, comorbidities, the gut microbiota disturbance, and you will see now that in mostly of the article is present. The use of antibiotics, that is another risk factor. It is a risk factor for general population too, to develop the infection. The use of non-inflammatory drugs within 2 months prior to hospital risk. To have a pancolitis instead to localize a disease, to use the drug. And another point is the use of antibiotics, and you see again dysbiosis, antibiotics use. So more or less that the risk factor are identified like the same. But if we move to this, this is one of the meta-analysis that the other one considered, but it was, I think, well conducted. So I'd like to show you, because you can see graphically very well which are the risk factor and we are not. For example, here you see the antibiotics use. You see the colonic involvement in IBD patients. If you check for the use of a proton pump inhibitor is not a risk factor. And why I say that? Because in general population, I will show this in another study, the use of proton pump inhibitor could be a risk factor to develop the infection. The male gender in this revision of literature is not a risk factor. And if you compare the different therapies, you see here that 5-SA are not in a risk factor like steroids in this meta-analysis, but in other one I will show you that it is. So like for every, I think, topic, we have some conflicting data. Biologics, they seems involved, and immunomodulator, they are not. But probably the biggest problem is related not just to the higher risk of infection related to increased susceptibility and of the in IBD patients to have this kind of infection, but the other problem is related to the increased cytotoxicity effects of clostridial difficile infection in patients with IBD, because there is an increased expression of toxin receptor that induce cell death by necrosis. This is an increased cell death by apoptosis, and this is an induction of cellular senescence. And because of this, we have an increase of necrotic cell deaths generally, but we have an increase of microbiome alteration that, as I showed you at the beginning, is one of the risk factors to develop the disease. So this is a problem for our patients. And another point, interesting point, is the possible precancerogenic role of the toxin because they induct these senescent cells with a risk of future relapse. This is a retrospective case control study. They evaluate patients with Clostridium difficile infection that was followed in their department for 18 years. You see here that the gray line is non-IBD patients, and the clear gray, and the other one is the IBD patients. So generally, the patients in this cohort, this is a case control study, the patients mostly involved in the infection are non-IBD patients. And what they saw is the age at first Clostridium infection is higher for patients non-IBD, and we can understand why, because it's a risk factor mostly from them, because for IBD patients, the risk factor is not related to the age, but is related to the disease itself. Patients with comorbidity are for sure older, so are mostly non-IBD patients that prior hospitalization or use of antibiotic is a risk factor, as we saw before. And in this case, the use of steroids or biological therapy is considered a risk factor too. And as I told you before, if for non-IBD patients, the use of proton pump inhibitors could be a risk factor, it is not for IBD patients. This is another study. This is a cross-sectional study on 85 UC patients with a Clostridium difficile infection, assessed for Clostridium difficile infection, because just 15 patients finally disease. They would understand which was the prevalence of infection, and they again looking for some risk factor like steroid treatment, previous surgery, severity of UC, and use of anti-inflammatory drug. And this study, and just in these retrospective studies in which they evaluate 137 patients with IBD and infection, Clostridium difficile infection, you can see here that BMI, so the body mass index of patients, seems related with the most severe disease, and the use of statin is related with a more severe disease too, more complicated disease too. What about the outcome in this kind of patients? So IBD patients, specifically UC patients with Clostridium difficile infection. Back to the use of steroids. In this case, the authors would evaluate what happened is after the diagnosis of Clostridium difficile infection, they receive steroids. So this cohort is bigger, fortunately a little bit bigger than before, 112 patients. And what they saw is that patients were treated with corticosteroids after the diagnosis. They have a higher risk of colectomy, a higher risk of intensive care urine admission, and the risk of perforation compared with patients that didn't receive steroids post Clostridium difficile infection diagnosis. And another things is that they have a length of stay in the hospital longer compared to the other patients. In this study, the point is a little bit different. So if patients are using were starting before to use steroids, in that case, if you modify the corticosteroid region, these don't affect the recurrence of infection or a risk of future exacerbation of IBD. But if you have a corticosteroid escalation, this could modify the risk of surgery in these patients. About adverse outcome, like risk of surgery, if you use antibiotics or if you use biological therapy, if you modify this regimen, you have no differences in patients that, for example, don't modify the regimen of treatment for ulcerative colitis disease. In these multi-center retrospective studies, they included a lot of IBD patients, and they saw what happened during if they escalate biological or steroid therapy. And it's interesting to see that if you think that if you have the infection, you have to stop your treatment for IBD, have a severe outcome because you have a worsening of disease and you have an severe other outcome, not related to Clostridium difficile infection. So it's important to treat our patients, probably to don't start steroids after the diagnosis, but to go on with the treatment or to intensify the immunosuppressant treatment together with the treatment of Clostridium difficile infection for sure. Another thing to know is that if you want to know which outcome could have your patients, you have to know that would be more severe if you have higher lactate and lower albumin or hypotension, for example. So it's very important to treat your patients for malnutrition, for example, or to give albumin if you have a reduction of albumin, because the outcome will be better. And if we look to short or long-term risk of colectomy in these patients, what we can see is that the infection did not increase the short-term colectomy in IBD patient, however, could have an impact in the long-term risk of colectomy in this kind of patients. This is another case control retrospective study. So the gray part is the prevalence of Clostridium difficile infection in all patients that were admitted in the hospital. And they use a propensity score in this case, because if you compare the number of patients with Clostridium difficile infection with control, the number is very small. So finally, they use 35 patients with infection and 70 control patients in this analysis. And what they saw is that patients with Clostridium difficile infection have a higher risk of readmission to the hospital. You see here the blue line is the survival line. So if you have not Clostridium difficile infection, you have a lower risk of readmission to the hospital. There is an increased mortality within the first 3 months post-discharge, and there is an increased need of therapy intensification in the first year after admission to the hospital. And the same thing is demonstrated in this other study published last year. So you can see here that the readmission in IBD patients with in fact correlated with Clostridium difficile infection hospitalization is higher, like the mortality of these patients and the severe hospitalization, for instance, or unplanned hospitalization, or the IBD-related procedure, because if patients have the Clostridium difficile infection, you have to understand sometimes if the problem is just the infection or if you have a flare plus infection and you need to treat more your patients. In this recent study, you see again which factors are related with the infection in IBD patients. So the use of anti-TNF and the antibiotic exposure come back. I showed you this because it's more recently and is not a review, but this is a study. And the variables that are associated to a worse outcome are the baseline 5-ST treatment. This is related with the activity of disease and again the hypoalbuminemia. In this study, we have a comparison between IBD patients and non-IBD patients with Clostridium disease infection. And again, we have some differences related to comorbidities, higher in patients without IBD, and the use of antibiotics higher in patients with IBD. And another interesting thing is that if we check the treatment of these patients, metronidazole is mostly used in a control group, and in our group, in IBD group, we use mostly fidaxomicin. I will show you something about therapy in a few slides. There is no differences if you compare the day to resolution of the diarrhea, or in these studies, if you compare the risk of relapse of infection, the mortality, and in or out the hospital. And another interesting thing to know is that if you have a cytomegalovirus infection, you have a higher risk to have a Clostridium difficile infection. But what is important to know, there isn't a significant increase in a high grade of disease in patients with these co-infections. But if you have the co-infection, you could have a higher risk of colectomy or a cytomegalovirus reactivation. What about diagnosis? I don't know. You have some section on Clostridium difficile infection, so just few words on diagnosis. What is important is that what we prefer to do is a two-step algorithm. Generally, we use the GADH, and if it's positive, means that the Clostridium is there, but it's important to know if you have the toxin. So we looking for the toxin. Another is no good if you just check the toxin. Is no good if you do just the PCR. You see, you have a false positive possibility, and low sensitivity if you use just the toxin. So this is the best. In the ECHO guideline for infection, there is the they propose to use the nucleic acid amplification technology, and it's enough just using one thing. However, it's really expensive. And another interesting thing to know is that in IBD patients, we have a low risk to see pseudomembranes, and for this, to perform colonoscopy in these patients is unuseful. So colonoscopy for the diagnosis of Clostridium difficile infection is not required. What about therapy? Again, this is the review that I showed you before. So mostly literature review from data from literature review, because the point is that we have not guideline dedicated to IBD. We have one small part, and I will show you on Clostridium difficile infection in the guideline for infection in IBD, but we have guideline dedicated to Clostridium difficile infection in general population in US, in Europe. Yeah, we have a lot in England. So we have a lot of this, but not in IBD. So I just show you what happened during the year, because this is a review starting from 2022, and as you see before, finishing 2018, I think. So the most recent review show us that vancomycin or fidaxomicin could be used, and in some case, complicated, or in case when you have a reinfection, you can use monoclonal antibiotic too, like actoxumab and bezlotoxumab. You see here that the data, the year of the publication, again, vancomycin and fidaxomicin. Another important role is related to the fecal microbiota transplantation. It's something that you don't find everywhere. This is the first point to know. That is not suggested as a first-line treatment, but could be suggested when you have a recurrence of disease. And if we move, look here, year by year, you find in 2018 metronidazole. Why I tell you that? Because recently the new guideline, not the IBD guideline, but the new guideline suggests to don't use anymore metronidazole because we have more effective drugs. However, if you see from the ECHO guideline published 2 years ago, so not a long time ago, you see that for initial episode, the treatment with metronidazole for 10 days is still suggested. You can see here, like in the other guidelines, that vancomycin or fidaxomicin are both suggested like treatment option in the initial episode. They observed that fidaxomicin is less really available, and I think that now is not like this because probably 2 years ago, but now it's more easy probably to have this drug. If you have a fulminant initial episode, they suggest to use vancomycin together with the intravenous metronidazole, and this is something very different from the other guidelines. And if you have the first recurrence, you can use vancomycin if you used fidaxomicin, for example, or fidaxomicin. The difference is that vancomycin is orally 4 times daily, fidaxomicin is twice daily. Fidaxomicin is a pill. Vancomycin for us, it's fluid, so they have to drink the vial, for example, in Italy. And if you have other episode of recurrence, here you can see the fecal microbiota transplantation. For example, in this guideline, they don't put the antibiotics, the antibodies in the treatment. And I took just one of the new guideline. This is from Europe, and you see here then the standard of care in the initial infection is fidaxomicin or vancomycin is the same, and at the first recurrence you can change it, and fecal transplantation is suggested at the second or after the second recurrence. And here you can see in the first or in the second the use of blezotocumab too. The use of blezotocumab I will not show you, but in IBD we have just one case control. One case study. They describe one case in one young male, they use it, but we have no data about that. So a few words, what we have about the use of fidaxomicin in IBD patients. Unfortunately, very few data. This is the anemone study that involve a lot of patients, 508 patients, but patients with condition of specific interest that were IBD, just 29, or fulminant disease, or renal impairment, or hepatic impairment. This is a retrospective study. It's interesting to see that the blue line is the IBD line, so when patients start fidaxomicin, they have a higher probability of survival compared with patients with other diseases. And they have a high rate of resolution of diarrhea, 81%. The time to resolution is just 2 days and something. The day of the 30-day recurrence is just 19%. So they show it good data in this setting of patients. We have this other retrospective again study in 33 patients, 26 with the UC. They follow up patients for at least 3 months. And what I can show you is that mostly they are patients that are more than one episode. 21% was at the first one, but they have an history of infection with Clostridium difficile. They were treated with one or more treatment before. Here you can see the previous treatment. And what they saw is that patients treated with fidaxomicin have a response in 20 is the number, is not the percentage, 20 patients on 13, without recurrence in 14 patients. And patients that didn't respond or had the recurrence could respond to other treatment, and in 2 cases, they needed a colectomy. Finally, we have the profile study. This is just the pharmacokinetic studies on 11 UC patients, so very low, but they would demonstrated was that plasma concentration observed in this kind of population, so in IBD patients, no increase in absorption is you compare with patients without IBD. And the clinical outcome in IBD patients, you see here the UC patients were very good. Clinical response after 12 days was 100%, with a recurrence rate that was 20%. Few words about fecal microbiota. This is a topic. We have a lot of review in this page. You see a lot of review. However, the number of patients in different studies not so high. In this review, recent published from an Italian group, we have 15 studies with more than 770 patients. However, if you look, we have a few patients in the different studies. But finally, what all of this study demonstrated that you can use fecal transplantation in patients not after the first infection with Clostridioides difficile, but if you have recurrence, and it could be effective. The problem is that, as you can see on this picture, you have to find the donors, you have to prepare, you have to inject it, so it's not so easy, and you can do it everywhere. In conclusion, the diagnosis of Clostridium difficile infection in IBD can be challenging due to the overlap of symptoms that I showed you on the beginning. In IBD patients, we have a 5 times increased risk of infection compared to general population. The recurrent Crohn's disease, the recurrent Clostridium difficile infection risk is also increased in UC patients and IBD patients generally. We have no specific line to manage IBD patients, but I show you what we do in our clinical practice, and fidaxomicin could be used in first line in our patients too. And thank you for your attention.